Hi, today we are going to be talking about post-transplant medications. My name is Keri Townsend, and I am the lung transplant clinical pharmacist. In this video, we plan to review your anti-rejection medications as well as your anti-infection medications that you'll be on after transplant. We plan to discuss appropriate timing as well as administration of your medications, and we will help you identify possible side effects of these medications as well as what to do if you experience them. We will review tools included in your diary that you will use to help develop a system to learn your medication regimen. We also recommend starting this while you're here at Brigham to ease your transition to home. Discuss expected patient responsibilities regarding your medications, as well as some tips to troubleshoot potential issues that may arise. So we're going to talk first a little bit about your immune system after transplant. Why do we need these medications? And really, we're using these medications to protect your immune system against rejection. The function of your immune system is to protect against disease. To do this, it must detect tissue that is healthy, this is self, against that which does not belong, non-self or foreign tissue. In a non-transplant patient, this typically means looking for bacteria and viruses. However, with a transplant, your lung is and always will be considered non-self or foreign. In order to prevent your immune system from identifying and attacking the new lung, we will give multiple medications, also known as anti-rejection meds or immune suppressants, to quiet or minimize this response. However, suppressing your immune system also puts you at risk for certain infections, and you will need anti-infective medications to prevent the more common infections we see after transplant. First, we're going to talk about your anti-rejection medications. You will be on 3 medications for life to quiet your immune system and prevent rejection. The first is called Tacrolimus. It has 2 brand names, Prograf and Envarsus. The second is Mycophenolate, brand names CellCept and Myfortic, and the third is prednisone. Tacrolimus is your most important anti-rejection medication. In order to make sure you get enough of this medication to prevent rejection, we always will have to do blood work to determine how much of this medication is in your body. This medication comes in 3 different capsule strength sizes, a 0.5 milligram capsule, a 1 milligram capsule, and a 5 milligram capsule. Likely you will have more than one strength of these capsules at home to make up your dose. It's very important to take these capsules whole. Do not cut or open them unless otherwise told. Periodically, if you're unable to take medications by mouth, we may administer this medication via G-tube if you have swallowing problems. In this case, you'll be given specific instructions how to open the capsule and take the contents inside. This medication is dosed twice daily, 12 hours apart. It's important to think about a time frame that is going to work best for you at home. We typically suggest taking this at 9 a.m. and 9 p.m., but this time frame can be adjusted to fit your daily routine. It is also very important to take this medication consistently with or without food. There are many interactions with this medication, including commonly prescribed antibiotics, over-the-counter medications, as well as foods, including grapefruit and grapefruit juice. Please call us before taking any new medications so that we can avoid complications from drug interactions. Tacrolimus Lab Monitoring is very important. In order to make sure you're getting enough of this medication to prevent rejection and not too much to have severe side effects, we will always have to check the level of tacrolimus in your body, and your dose will change frequently as we try to keep this level within a specific range. This blood test will be checked every time you come to clinic. The lab test timing is very important. It needs to be what we call a trough level, which is checked right before the morning dose and as close to 12 hours after the evening dose as possible. On the night before and the morning of clinic, we will ask you to rearrange the timing of your tacrolimus to get an accurate level. Please plan to come to Brigham 1 hour before your scheduled appointment for labs and chest x-ray. The night before your appointment, please take your tacrolimus 12 hours before you plan on getting the blood work done. You do not need to be fasting for your routine clinic blood work. Please eat and drink as normal for these labs. For example, if your clinic appointment is at 11:30 a.m. on a Wednesday, we will ask that the night before you take your tacrolimus at 10:30 p.m., 12 hours before you plan on being here for your labs. Come to Brigham around 10:30 on Wednesday morning to have your blood work at 45 Francis Street. Please take your tacrolimus dose after your blood work has been drawn, and then go get your chest x-ray, and then head to your 11:30 a.m. clinic appointment. That evening, you can resume your tacrolimus at the normal time. Tacrolimus has many side effects to monitor for. The most frequently that we see is an intention tremor. This means your hand may shake, and it will be worse when you go to do something like write something down or pick up a spoon or a fork. We can also see headache and kidney problems. Kidney problems are not uncommon with this medication, and part of the reason why we are monitoring your levels very carefully. We do see worse kidney problems when your tacrolimus levels are high. Long-term, we can also see issues with high blood pressure, high cholesterol, and hair thinning. Low magnesium is not uncommon. This often requires supplementation, and you can also increase your intake of magnesium-rich foods, including green leafy vegetables, string beans, legumes, nuts, and avocados. Elevated blood sugars are also not uncommon after transplant. You will go home with a glucometer to monitor your blood sugars at home. Most patients will also go home with insulin injections to help control blood sugars. Please work with your nurse to start learning how to inject insulin while you are here in the hospital. Mycophenolate mofetil, or CellCept, is your second anti-rejection medication. This comes as a 500 milligram tablet, a 250 milligram capsule, as well as an oral solution. These tablets cannot be crushed or split. So if you have difficulty swallowing this medication whole, please let us know and we can change it to a suspension. There is an alternative called mycophenolate sodium, or Myfortic, available as well, which comes in 180 and 360 milligram tablets. This medication has a standard dose. We really do not change this dose frequently unless you're not tolerating the medication. The typical dosing is 1,000 milligrams twice a day, 12 hours apart. With Myfortic, the dosing would be 720 twice daily. At home, we recommend you take this at the same time you take your tacrolimus. Again, consistency is important, and we recommend you take this with or without food consistently. Typically, with food may help prevent some stomach upset. The main side effects we can see are usually GI or stomach related. We can see nausea, vomiting, and diarrhea. These are very common side effects with all of the meds you're on, so it may take us a little while to figure out which med is causing this if you are experiencing these side effects. We can also see low white blood cell counts, and we will monitor for this on your blood work. Sometimes we may have to drop or temporarily stop this medication if your counts are too low. Mycophenolate also has concerns in terms of women of childbearing age if you were to become pregnant while on this medication. It can cause birth defects if taken during pregnancy, and the FDA recommends taking precautions to prevent pregnancy while on this medication. Prednisone is your third anti-rejection medication. This is a steroid. You'll remain on prednisone for life, though the dose will change over time. Early after transplant, you will be on high doses of steroids, which will be tapered down over about 3 months to 5 milligrams once daily. We will give you a schedule of dates to taper your prednisone before you leave the hospital. This medication comes as 5 milligram and 10 milligram tablets, and again, you'll likely have more than one strength at home to make up your dose adjustments. Typically, this medication is taken once daily, and we recommend taking it in the morning as it can cause difficulty sleeping at night. Steroids are also the main treatment for rejection. If we are concerned about rejection or detect rejection on your surveillance biopsies, we will increase your steroid dose. Typical treatment is admission for 3 days of IV steroids and a new prednisone taper, which will taper back down to your prior dose over a few weeks. Prednisone has many side effects. Most commonly, we see high blood sugars early after transplant. So it's important to be prepared to go home with a glucometer to test your blood sugars at home, and potentially you may go home with insulin as well to treat these high blood sugars. We can also see high blood pressure, increased appetite and weight gain, difficulty sleeping, mood swings and irritability, And long-term, we worry about effects such as weakened bones like osteoporosis and eye problems such as glaucoma. Because we've started all these new anti-rejection medications and are suppressing your immune system, we also worry about preventing certain infections after transplant. And in order to prevent these infections, we will give you medications, anti-infectives. Hand washing is also the #1 key to stopping the spread of infection. You'll be on these anti-infective medications to prevent the most common infections we see after transplant. These are called opportunistic infections. These infections can be bacterial, fungal, or viral. The duration of these anti-infectives will be between a few months to lifelong, depending on the risk each infection poses to your new lungs over time. The first infection that we try to prevent is called Pneumocystis jiroveci pneumonia, or PJP. This type of pneumonia is easier to prevent than to treat because it can directly affect the new lung. We will keep you on this medication for life. There are 2 options in terms of preventing this infection. The first is called Bactrim. Bactrim is a combination of 2 medications, sulfamethoxazole and trimethoprim. And there are a few different dosing schedules that you may be on. This comes as a single-strength tablet, which is 480 milligrams of sulfamethoxazole and 80 milligrams of trimethoprim, and also comes as a double-strength tablet, which is twice as much medication, 800 of sulfamethoxazole and 160 of trimethoprim. You may be on a DS or double-strength tablet 3 times a week, a single-strength tablet once daily, or a double-strength tablet once daily, which also covers another infection called toxoplasma. This medication is fairly well tolerated, although we can see increased potassium, and it will increase your sensitivity to sunlight, so wearing sunscreen is very important. If you are unable to tolerate this medication, either due to allergy or intolerance due to high potassium levels, you may get switched to an alternative medication called atovaquone, brand name Mepron. This medication comes only as a suspension and is dosed as 1,500 milligrams or 10 milliliters once daily. It does not have the same effects on potassium, but can cause some GI upset and potentially headache or dizziness, although overall is well tolerated. These medications, again, will be on for life. We also worry about viral infections after transplant, mainly Cytomegalovirus, called CMV, or Herpes simplex virus, also known as HSV. These viruses never leave your body, but remain dormant and can reactivate when your immune system is suppressed after transplant. You'll be on antiviral medications for up to a year after transplant to help prevent these viruses. In order to determine which medication you need, we will check both you and your donor to determine if you've ever been exposed to these viruses, and this will determine how long you need to be on these antiviral medications. So in terms of your donor status and your recipient status, we will see if you've been exposed or never been exposed. The risk for CMV infection is highest if the donor has been exposed to CMV and you have not been. This means you'll be on these antiviral medications for a longer period of time. We have a few different options in terms of preventing and treating CMV infections. Valganciclovir is our first choice and what you'll be placed on early after transplant. This medication helps cover both CMV and HSV viruses. It comes as a 400 milligram tablet as well as an oral suspension, and the dosing will change depending upon your kidney function. Unfortunately, this medication can cause low white blood cell counts, and occasionally we will have to take you off of this if you experience low white blood cell counts. In place of this, we would put you on a medication called Prevacid or letermovir. This medication only covers CMV, and so if we have to switch you off valganciclovir, we would also need to add valacyclovir or Valtrex to Prevacid so that you would have coverage for both the CMV virus and the HSV virus. Prevacid comes in both 240 and 480 milligram tablets and is dosed once daily. This is typically well tolerated, though can cause some GI side effects. If we are not worried about CMV, meaning that both the donor and recipient are CMV negative and have never been exposed to CMV, then you'll be placed on valacyclovir alone to help prevent the HSV or herpes simplex virus. This comes as a 500 milligram tablet, and again, the dosing may depend on your kidney function and adjust as your kidney function changes. Side effects include nausea, stomach pain, and headache. We are also concerned about fungal infections after transplant. We worry about yeasts and molds. Yeasts such as Candida can cause infections such as thrush, and to prevent this, you'll be on a nystatin swish and swallow suspension that you will take 4 times daily to prevent oral Candida or thrush. You'll be on this until your prednisone dose is down to 5 milligrams. If you are cleared to swallow thin liquids after your transplant surgery, then it is preferred that you will swish and swallow this medication. However, if we are worried about aspiration and you are not cleared to swallow thin liquids, then it's more important to spit this medication out. Please do not eat or drink for 15 minutes after taking nystatin. If your cultures from transplant show any additional Candida, you'll be placed on an oral antifungal instead of nystatin, and this medication will be on for about 3 months. While hospitalized, you'll be on an inhaled medication to prevent mold such as aspergillus from being colonized in the new lungs. This is called amphotericin and will be nebulized 3 times a week to help prevent this. This is only while you're here in the hospital and will be stopped at discharge. If your cultures from transplant grow any mold such as aspergillus, then we'll place you on a systemic or oral antifungal medication, again for 3 to 6 months after transplant. Oral antifungal medications interact with your tacrolimus. When they are started and stopped, we will need to make significant dose changes to your tacrolimus, and you will require more frequent monitoring of your trough levels. A few of our common antifungal medications include fluconazole, otherwise known as diflucan. This medication covers most candidas, and the dosing is again based on renal function, so may change over time. In terms of side effects, we can see increased liver function tests, as well as a prolonged QTC. QTC is an interval found on your EKG, which is a measure of your heart rhythm. Another antifungal medication you may be on is called isavuconazole or Cresemba. This medication covers aspergillus, is dosed at 372 milligrams once daily, and can cause GI side effects and will lower this interval in your heart called the QTC. Voriconazole is a third antifungal medication. This medication covers aspergillus, is dosed twice daily, and the dose may change as based on levels, similar to your tacrolimus. In terms of side effects, this can cause increased liver tests, again a prolonged QTC, and also causes much sensitivity to sunlight and increased risk for skin cancer. So again, wearing sunscreen is very important. The fourth antifungal medication that we occasionally use is called posaconazole or noxafil. This one also covers the mold called aspergillus, is dosed once daily, and has similar side effects, including increased liver tests and some GI side effects. In addition to anti-rejection and anti-infection medications, you will be on medications to prevent common complications after transplant, as well as medications that are specific to you. These may include medications to lower both your heart rate and prevent atrial fibrillation. This would be something such as a beta blocker called metoprolol. Medications to prevent blood clots. This includes injectable heparin or injectable enoxaparin, also called Lovenox. Medication to treat blood pressure, medication to prevent heartburn and reflux, injectable insulin to lower your blood sugars, and vitamin supplements such as calcium and vitamin D to help keep your bones strong, as well as magnesium. At transplant, we will also reevaluate medications that you were on prior to your surgery. Medications that you may have been on before transplant to treat depression, anxiety, thyroid problems, cholesterol, etc., will likely be continued after transplant. If these medications interact with our transplant medications, we may change them to something else. Please let us know if you have any questions or concerns about your pre-transplant medications and what should or should not be continued after transplant. Learning your new medication regimen after transplant is very important. Before you go home, we want you to know the name of each medication, when to take each medication, how to take each medication, major side effects of each medication, why each medication is needed, food or drugs to avoid while taking each medication, what to do if you miss a dose, and how and when to refill these medications. There are many different routes of administration. Not all of your medications will be pills. Some of them may be liquids, some of them may be IV infusions, and some definitely will be injectable medications. Blood thinners such as heparin or enoxaparin are injectable medications that you'll be on for 1 month after transplant. And it's also not uncommon to go home with injectable insulin to lower your blood sugars while your prednisone is coming down after transplant. Please work with your nurse to learn how to do subcutaneous or under the skin injections and practice these before going home. Some patients also have difficulty swallowing after transplant, and it may not be safe to take medications by mouth. If this is the case, your medications will be crushed or liquid and given through a feeding tube. If this happens, you'll receive additional teaching in terms of how to appropriately crush and administer medications through the tube. It's very important that these medications be crushed finely so they do not clog the tube. We do recommend starting to learn this regimen while you're here at Brigham. There are multiple tools in your transplant diary that will help you. Please start reviewing your transplant diary as soon as you get it. In the back of your binder, there is a medication schedule to document your medications while you're here in the hospital. Please work with the floor nurses to start learning your new transplant meds. They will give you the names of the medications and tell you what they are for as they administer them to you. Please start checking off your medications on the med schedule as they are administered. This will help you learn the names of the medications and make it easier to understand your regimen before you go home. You'll also have a teaching session with your transplant pharmacist and you and your family to discuss your specific transplant medication regimen in specifics before you go home. You'll be given a list similar to what you see on the right, called a medication planner. As you can see in this medication planner, on the left-hand side, you have the names of the medications, the generic name on top with the brand name underneath. The next column has the dose of the medications. And again, this will be as of the time that you were given this medication planner, since the doses change frequently. The following column has the use or why you take each medication. And then on the right side of the med planner, we have 4 columns broken down into different times during the day to help schedule when to take your medications. Typically, we recommend taking the medications around meals and again at bedtime. We will work with you to simplify this regimen as much as possible, and this is again scheduled in a way that you can use a pill box to separate out your medications throughout the day. It's not uncommon to have medication issues, and so it's important to know how to troubleshoot these. Preventing complications with your medications is the most important thing. And taking your anti-rejection medications as prescribed is really the best thing you can do to prevent rejection. It's very important to not run out of your medication. At discharge from Brigham or from rehab, we will get you your first month of medications from Community Walgreens. This is a specialty branch of Walgreens that has the transplant meds. They will deliver 1 month worth of medications as well as a care package including a pill box, a blood pressure cuff, thermometer, and pill splitter to either the Brigham or the rehab that you're at. After the first month, you can continue to receive your medications from Community Walgreens and they can mail them to your house, or we will happily go back to your local pharmacy if that's what you prefer. Please let us know in clinic after you've been discharged what your plans are in terms of refilling your medications so we can make sure to have your prescriptions sent to the right place. I do recommend that you do not rely on automatic refills. Please stay on top of your medications and when they need to be refilled. If you use your pill box and fill it up once a week, you'll know about a week in advance when your pill bottles are getting empty. And this is the best time to call the pharmacy to ask for refills on your medications. It's also very important to keep track of how many refills are left on your prescription. In general, prescriptions are only good for up to 1 year, and after that, the doctor will need to send a new prescription to the pharmacy. Please call your outpatient coordinator for any new prescriptions that you need. Insurance issues are common after transplant, and unfortunately, these take time to fix. Certain prescriptions may require prior authorization, which means that the transplant team must fill out a questionnaire for the insurance company to show why we are using the medication and to see if it matches their criteria. If the prior authorization is denied, then we will need to write a letter of medical necessity explaining why we think this medication should be approved despite not meeting the insurance company's criteria for use. If we're unable to get insurance coverage after all these steps, or if the medication is too costly, we may try to consider using a different medication or to get the medication through patient assistance if it is available. If we decide to get medication through patient assistance, we will ask you to fill out paperwork, which may include asking for financial information such as your yearly income to see if you meet the drug company's criteria for acceptance. Please let us know as soon as possible if you are having prescription insurance issues so we can come up with a plan so that you do not miss your important medications. There are many drug interactions with your anti-rejection medications, including common antibiotics and over-the-counter medications. Please call us before starting any new medications, even if these are prescribed by another doctor. We want to be proactive to prevent complications from interacting medications before you start them. In terms of over-the-counter medications, there is a section in your transplant diary which has a list of medications that you can take and what you should avoid. However, if there's anything that is not on that list, please call us first. In general, we will ask that you avoid herbal supplements. However, if there's a specific one you are interested in taking, please call first to see if it is okay. However, I must say that in general, 95% of the time, I will ask you to avoid it. In terms of foods that interact, we will ask you to avoid any grapefruit or grapefruit-containing products such as Fresca, as this will increase your tacrolimus level. Your main responsibilities in terms of your medications after transplant, number 1, are to take your medications every day as prescribed and to refill your medications on time. Again, this is the best way to prevent rejection and is in your hands. Number 2 is to know your medications, what they're for, what the dose is, the frequency, your side effects to watch for, and drug and foods to avoid, and what to do if a dose is missed. Please start this while you're here in the hospital. As you come to clinic, we will be asking you questions about your meds every time you come to clinic. And 3, most importantly, call us with any questions or concerns. We are here for you. If there's a problem getting medications from your pharmacy, if you are experiencing side effects before starting a new medication, or any other questions, please call us.